So you read the last line first, then you quickly give the options a look, and then you read the question. Or you can, directly read the question and look at the options later. It is totally up to you. Practice and you'll know what suits you best. So for example, I read the last sentence and now I'm looking at the options. Okay. Now standing, hand grip, left lateral decubitus, expiration, hand grip, standing, and rapid squatting all increase after load. That is what I know. And expiration causes increases your left heart preload. Okay. Left lateral decubitus will also increase your preload, or rather even after a bit. Okay, fine. So this is what I know. Sorry, your hand grip and rapid squatting will increase your afterload, standing will decrease your afterload because there will be peripheral pooling of blood. So from what I know, two are increasing preload, two are increasing afterload, one is decreasing afterload. So I already have an idea that standing is the odd one out here. It is the only one that is decreasing the blood volume of the left heart. Now I need to know, now there's a 44-year-old man, okay, rheumatic fever, okay. He has a late systolic crescendo murmur with a mid-systolic click, best heard over the apex, loudest just before S2. Now I need to diagnose what condition this is. So what I need you to remember whenever we're discussing. Now, I'll not be discussing theory in detail. You'll have to refer to your books. I'll be talking USMLE point of view. What is the easiest way to recollect what valve is being talked about and what kind of murmur, so right, systolic or diastolic murmur that we're talking about, right? So we have our systolic murmurs, we have our systolic murmurs, and we have our diastolic murmurs, right? Now, in systolic murmurs, you remember AS, that is our aortic stenosis, right? We can remember this easily. Why? Because S and S, okay? As systolic, okay? Now just go opposite everywhere. So because this is systolic, because aortic stenosis is systolic, aortic regurgitation is going to be opposite. I'll just fill in the blank from remembering this one fact, okay? Now what happens is your aortic valves go opposite to your AV valves. So because aortic stenosis is here, we will have MR here, mitral regurgitation. Opposite of the aortic valve is what you'll get here, okay? So your MR or TR, both will be systolic sounds, okay? And because we have MR and TR here, we'll have opposite of it, MS in diastolic. Okay, sorted. Now we just need to remember that MVP is a systolic one, and your PDA is a continuous murmur. So your PDA will be both systolic and diastolic. Okay, these are two extra murmurs. There are systolic ejection murmurs also. We'll not talk about it right now. Okay, so this is easy to remember. Now we have a late systolic crescendo murmur. It is systolic. So it is either AS or MR. Okay, MR or TR. TR is usually right-sided, not seen unless it is a drug abuser or something, or it is some infective endocarditis that we are talking about. So we have a late systolic murmur, and it is heard best over the apex. Now this is important. Your aortic stenosis. Here is your aortic valve. Here is your mitral valve. Okay, just imagine this is your heart or something. Just imagine that. Okay, I'm not really drawing it well here. But this is your mitral valve. This is your aortic valve. Here is your neck. Here is your diaphragm. Okay. Now, because this is closer to the neck, the murmur will be radiating to your carotid arteries. Your aortic stenosis murmur will radiate towards your carotid arteries, toward the base of your neck. While because the mitral valve is closer to the apex, you'll be hearing this murmur near to the apex. So whenever you hear the word apex or anything, just assume that we are talking about your mitral valve. Okay. And so yeah, so this has a mid-systolic click. Now mid-systolic click can be seen in MVP, and MVP can compromise your valve, so it is easier for a rheumatic patient to get infected, and then it can later develop into MR. Okay, so if the MR is very mild, it will give a late systolic crescendo murmur. Now these are features per se of MVP, but you can also see it with MR when there is an MVP superimposed with MR. So here, if the MR is mild, you'll see a late systolic crescendo murmur, and if the MR is severe, you'll see a hollow systolic murmur. Okay, this is hollow systolic. I'm sorry. Just imagine it is like continuously throughout. Okay, yeah. So because we have a history of rheumatic fever, MR is more likely, but a mid-systolic click can indicate towards MVP also. Please remember that. I guess we are done here. What you also need to remember is there is a septal defect that mimics the murmur of mitral regurgitation or tricuspid regurgitation. Which heart septal defect mimics the murmur of MR or TR? That is, which septal defect has a hollow systolic murmur? If there is an infant, if there is a 3 or 4 month old infant, and that infant is presenting to you with a hollow systolic murmur, what will you suspect? Ventricular septal defect. Good. So because TOF might have a ventricular septal defect component, it can present with that. But specifically, it is a ventricular septal defect. Now, what you also now just fun fact, what you need to know about VSD is these are your two ventricles. Just assume, okay, whatever it looks like. And this is your interventricular septum. Now, what happens is embryologically there is an opening. This interventricular septum is not present in this much area, which is why the blood from your left heart freely flows into your right heart because there is a pressure gradient. The pressure in your left heart is greater, so your blood flows into your right ventricle. So the oxygenated blood is again going to the right ventricle. This is your ventricular septal defect. Now, when the ventricular septal defect is very small and benign and not causing any symptoms, it tends to cause a louder murmur. So if you are hearing a louder murmur with VSDs, it is probably just small and it will heal on its own. In an infant, of course, after a few years of waiting, if it is not getting treated, you have to intervene. But if this VSD is bigger, right, then it will not produce a murmur. Why? Because there is no turbulence to the flow. There is a very big opening. The blood is easily passing through. But when the opening is small, see, that is why you play the flute, because there is a very small lumen of the flute which makes the sound come out, right? Because there is a turbulence to the airflow. Similarly, with a smaller VSD, there is turbulence, greater turbulence to the blood flow. So the louder the murmur, the smaller the VSD. Okay, remember this. Okay, now for your murmurs, I hope this is helpful. Just write this down. So you will be given a rough paper with you on your test day. You'll be given a whiteboard or a rough sheet. If you're having trouble remembering your murmurs, just go and write systolic aortic stenosis. The rest you'll be able to figure out based on common sense. Okay. What we need to know is which of the following maneuvers would most likely cause an earlier onset of the click or murmur. Okay, now usually uh, because see this mid-systolic click is very classical of MVP. I'll be taking it as MVP. There is a history of rheumatic fever and there might be a component of MR, but a mid-systolic click is heard in a mitral valve prolapse, and we'll be talking about it here because they are asking for the clicks. Okay, now three things you need to remember here, three murmurs or their see. I'll talk about the basic. Okay, this is your right heart. This is your left heart. Now, these are very important topics, so I'll be taking a little bit more time. If you want to write it down, please feel free. This is your right heart. This is your left heart. Now, what happens during inspiration? Your lungs are expanding. So there is an increased preload. There is a suction effect from the lungs. So the venous return is increasing. So your right heart is facing uh, more preload, okay, because of increased venous return. Because there is more preload, there is more blood, which means all the right sided murmurs will worsen, will become louder. Your TR will become louder, TS will become louder, PS, PR, all your right sided murmurs will become louder during your inspiration because of increased venous return. Now, in case of your left heart, whenever you expire, the pulmonary resistance is increasing. So overall, your left-sided preload or your pressure will increase. And the opposite happens during expiration. Your left heart sounds will worsen. Okay, this is the basic idea. Now there are three particulars that you need to know. So any condition that will increase your preload or will increase your afterload will worsen your murmurs. Okay, so when we talk about hand grip or your rapid squatting, what happens is they increase your peripheral resistance, hence they increase your afterload. So whenever afterload is increased, a murmur will worsen. Afterload is decreased, murmur will decrease. It depends on blood volume. The more blood you give, the more turbulence there will be. Then there are two others. Your expiration, as we talked about, it will worsen a left-sided heart murmur, and your left lateral decubitus position will again cause increased preload, because you're on your left there'll be increased preload, there'll be increased afterload overall, so it will be increased in your left-sided murmur. What happens in standing? In standing, all your blood is getting pulled to your periphery suddenly. Okay, so there is a rapid decrease. There is a decrease in your preload. There is a decrease, so there is a decrease in your blood flow. So the murmur will lessen. Now, how do you know? How do you determine with the click? In MVP, as the LV volume increases, the mid systolic click delays. Okay, which means in this case, in your standing position, when the LV volume is decreasing, when your here it is. Wait, I'll just erase this so that you can see it here. Okay, so what happens is when your LV volume is decreasing, there is an earlier mid systolic click. Okay, just to know, when the blood is less, there will be an earlier click. When the blood is more, there will be a later click. Okay. Two more things you need to remember, that is your HCM and your AS. So this is your these are your valves. Okay. This is a IV septum. So what happens in a hypertrophic cardiomyopathy? It is a genetic condition. There is a defect in your muscle fibers. Yeah. So murmur becomes louder when preload decreases. HOCM is your exception. That is exactly what I'm implying. Now what happens in your HOCM is, okay, see, this is a hypertrophic cardiomyopathy. It is myosin binding protein C and beta myosin heavy chain involvement. There is a mutation in these sarcomeric genes. So what happens is there is a hypertrophy of your heart with an excessive hypertrophy in your interventricular septum. Now, because of this excessive hypertrophy in your interventricular septum, what happens is, while the left heart is trying to pump blood, this is just your left ventricle, okay? Here is our aortic valve. Here is our aortic valve. Here is your mitral valve, okay? So what happens in hypertrophic cardiomyopathy? This septum is excessively hypertrophied. So we already have very less space through which your blood can enter the aorta. And once the blood, when the ventricle contracts and pushes the blood outside, because of this suctioning pull, this space further collapses. Okay, blood is going, it will collapse, going. So you remember, just remember drinking water or anything through your straw. Once you drink it, the straw will collapse, right? So that is what happens here. So it will give a murmur that is similar to your aortic stenosis, because that is what happens in stenosis, right? This aortic opening is narrowed, it is stenosed. Now, what is different is aortic stenosis is persistent throughout. Aortic stenosis is here to stay, while your HOCM occurs only while your blood is going out of the heart. Okay, it is kind of a dynamic stenosis that we are talking of here. Now, what we need to remember is in aortic stenosis, it follows the regular rules. During expiration, the murmur will increase. If the afterload or preload are increased, it will increase. HOCM goes exactly the opposite. If you increase the preload, if you give it more blood here, it will create a lesser suctioning force. So a greater preload will help this space remain open. So a increase in preload will decrease the murmur of HOCM, whereas it will increase the murmur of aortic stenosis. Exactly the same with afterload. As you increase the afterload, the pressure gradient changes and HOCM murmur will decrease, AS murmur will increase. Okay. So just remember HOCM and aortic stenosis will have similar murmurs but will have opposite trends with her afterloads and preloads.
Thanks for watching. Please give a thumbs up and subscribe for more.